Morgan. I was given the assignment of prostate cancer. So this is case 72. The case introduction. J.A. is a 53-year-old African-American man. He presented to the clinic for his yearly routine physical. He has no complaints and does not currently have any difficulties with urinating, pain, or swelling. He has no drug allergies. He does not take any medications besides naproxen, which he uses for occasional headaches. Interesting fact about naproxen and NSAIDs. They can actually decrease PSA levels in the blood or mask them. So this patient's levels may be significantly higher than presented due to his intake of naproxen if he weren't taking the naproxen. The provider should educate the patient on this fact, and the patient can then make an informed decision on whether he should continue taking his medication or not. But anyway, he has a significant family history of cancer. Both his father and his maternal grandfather have had prostate cancer. He is a current smoker and has a history of 75 pack per year smoking. He does drink alcohol on occasion, but overall his diet is healthy and includes a very few saturated fats. He eats a lot of fresh fruit, vegetables, and whole grain foods. And then his present hospitalization was he just presented to the clinic for his annual exam. Prostate cancer is a cancer of the prostate gland. The prostate is responsible for the production of semen. The muscles in the prostate gland help with expelling semen up and out of the urethra during ejaculation. Prostate cancer is the second most diagnosed cancer in men and consists of 26% of all cancers in men. The incidence of prostate cancer is higher in African American men, and it is the second highest cause of death in men. Some contributing factors to prostate cancer include the use of anabolic steroids, arsenic exposure, cadmium exposure, the firefighting occupation due to exposure of chemicals on site, malathion exposure, night shift work, the consumption of red meat due to high fat content, the rubber production industry due to exposure of carcinogenic chemicals, thorium-232 exposure, and X and Y radiation. Detection is typically performed via a digital exam, so the prostate is located beneath the bladder above the pelvic floor muscles. Behind the prostate is the rectum, so it is possible to feel the prostate gland during a digital rectal exam, which is an exam that consists of the healthcare provider's fingers being inserted into the rectum. While invasive, it's generally an easy and quick exam that is not costly and does not require much effort. The presence of prostate-specific antigen in the blood can also help detect issues with the prostate gland, whether this be cancer or benign prostatic hyperplasia, BPH, or inflammation. This protein is produced by the prostate and can be indicative of issues with the prostate gland. If abnormality is noted in the digital exam or if PSA levels indicate, a biopsy may be performed. Additional imaging such as MRIs can also help detect problems, and prostate issues can also be incidental findings within MRI results for other indications. The pathophysiology of prostate cancer begins with genetics. Why prostate cancer occurs is not definitive, and there is not sufficient evidence to place a certain reason behind it. However, genetic mutations that are inherited by close family members likely will play a role in the development of prostate cancer. Mutations in prostate cancer occur in the glandular cell's DNA. BRCA1 and BRCA2 mutations, specifically BRCA2, are linked to breast and ovarian cancer in women, but have been shown to be related to prostate cancer in men. HOXB13, which is a mutation in the genes of the cells of the skin and the male reproductive system, has also been shown to have relation to prostate cancer due to the inability of tumor suppression that the HOXB13 gene is responsible for normally. Prostate cancer is an adenocarcinoma due to its origination in the glandular epithelial cells of the prostate. The mutated cells or genes cause abnormal cell proliferation and growth, causing hypertrophy of the prostate as evidenced by digital exam. Prostate cancer begins in the peripheral basal cells. These cells gain the ability to move and break away from the initial site through the process known as metastasis, allowing the cancerous cells to spread to surrounding tissues. Commonly, prostate cancer can spread to the bones, lymph nodes, surrounding organs and tissues, lungs, liver, and the brain. These cancerous cells then can form tumor nodules through a process known as tumor initiation. This occurs when cells with genetic mutations multiply uncontrollably. Prostate cancer is hormone-driven and is specifically androgen-dependent. These androgens bind to and subsequently activate the androgen receptor, or the AR protein, in the cells of the prostate. This then causes stimulation of the expression of genes that causes these cancer cells cellular growth and survival. The clinical manifestation includes objective, subjective, labs, and PSA history. The patient presents to the clinic with an overall normal review of systems assessment. Vital signs are within normal limits. The patient does not present with any complaints currently. There are no abnormal labs noted other than the patient's PSA history. Since the patient does have significant family history of prostate cancer, he has had serum PSA levels drawn for the past 5 years. These numbers have steadily inclined from 1.7 5 years ago to 4.7 last week, and this can be indicative of prostate cancer and leads to further investigation. The rectal digital exam found mild enlargement of the prostate and a 2 centimeter indurated nodule. This patient did undergo a transrectal ultrasound, which resulted in the finding of a primary tumor found in less than one-half of one of the lobes of the prostate gland. An MRI scan was conducted, which revealed no metastasis or spread of the cancer to any lymph nodes or organs, but instead it has remained confined to the prostate. And the scans also showed that the tumor has remained encapsulated and not penetrated through the capsule. All good things. The role of the advanced practice nurse. Taking an accurate patient history can help determine which patients are at higher risk for certain diseases like prostate cancer. Family history is one of the highest risk factors in prostate cancer, so accuracy of health data collection should be a priority. A thorough assessment of all systems is important as well. Digital rectal examination, assessment of lymph nodes for tenderness and swelling, gathering subjective data regarding genitourinary discomfort or dysfunction. The review of past lab results, such as the PSA levels in this patient's case, will help identify how severe of a risk this patient has for prostate cancer. Gathering social history is also very important. In this instance, the patient is a heavy smoker with a 75 pack per year smoking history, which also increases his risk for many different kinds of cancer and not just prostate. He also does drink occasionally, and drinking is not safe in any amount scientifically, so it could be contributing to his cancer diagnosis as well. The advanced practice nurse should thoroughly educate the patient on smoking cessation and maintaining a healthy weight with exercise and low-fat diet. Support should be shown to the patient in this time of new cancer diagnosis, and the nurse should provide resources for support groups, counseling, and smoking cessation programs in the area. Follow-ups should be scheduled, and the nurse should ensure the patient is educated on disease progression and common symptoms to experience with prostate cancer. Treatment options should be discussed, and the patient should be able to make informed decisions in his care and management of prostate cancer. It is a good thing that this patient was being followed closely regarding his PSA levels and digital exams yearly. The cancer was able to be diagnosed early, and there is a much better prognosis associated with early diagnosis in this form of cancer. Case questions. So the first one is identify this patient's 2 major risk factors for prostate cancer. I put 3 on the slide, and it can be 3. The age is a significant factor. So the more increased age of the patient, the more increased risk of prostate cancer. This patient is 53, so a little early for general population prostate cancer. However, since his family has a significant history, it puts him in a category that needs to be screened more closely. The second factor is family history of prostate cancer. I also included smoking and African American descent, because those people are at increased risk for prostate cancer. The second question is, which two clinical manifestations shown in the physical examination above should concern the primary care provider? Digital rectal examination findings of a nodule on the prostate and then elevated level of PSA. These both indicate concerning issues with the prostate. The third question is, transrectal ultrasound showed that the primary tumor was found in less than 1/2 of one of the lobes of the prostate gland. The MRI results revealed that prostate cancer has not yet spread to the lymph nodes or surrounding organs, but has exclusively remained in the prostate. Furthermore, the prostate appeared to have remained in the capsule in the prostate. Which stage accurately describes this patient's cancer? It's stage 1. Since the tumor has remained in its place of origin without spreading or penetrating through its capsule, it remains stage 1. And these are all the references I used for this week's presentation. Thank you for listening.